Good morning and good afternoon for all our guests and viewers all over the world. This is the 26th episode of the fetal series in the Congenital Heart Academy, and this is our third year. We're back after the summer holidays and after the beautiful World Congress. I hope most of you came and enjoyed it. And today, we have three important speakers and topics. And I'd like to introduce the first speaker, my colleague and friend, Dr. Gary Sato. I'll let everyone introduce himself if possible. Gary, you're the first one to go. Thank you.
Thank you, Rima. Good morning, everybody. Yes, so I'm Gary Sato, and I'm Director of Pediatric Echo and Co-Director of Fetal Cardiology here at UCLA in Los Angeles. And unless you want me to move on to slides, I'll let my colleagues introduce themselves.
Each one will introduce himself or herself at the time. You can,
Okay.
You can go to your topic. Thank you.
So can you see my slide? Okay.
Yes.
Okay. So thank you, Rima and colleagues, for asking me to speak today. I actually had initially planned to speak about three very interesting cardiac tumor cases we've had in the last few years, but I realized soon enough that the time would really only allow for one of them. So I've chosen to pick a recent case of ours, show a little bit of the fetal imaging, talk a little bit about the management and outcome, and then a very brief review. So here's the case. I saw a patient on a Friday. She was about 32 years old, prima gravida, about 28 weeks and 2 days gestation. The FW was about 1,400 grams, and the referral indication was for a newly found mass, which just happened to be identified for a growth scan that was done in the third trimester. So here's my scan, again, at about 28 weeks. The first time I'm seeing the patient, and I think that everybody on the call should be able to identify what we're looking at here, which is the heart. And here's our kind of four-chamber view with the atria, the ventricles, the apex of the heart. Here's the pericardial space with a large effusion, and of course, a very large mass adjacent to the right atrium and anterior to the aorta. So as soon as the probe was put on chest, obviously confirmation of the referral indication, the mass was confirmed. Here, turning the transducer to a kind of sagittal plane, we see again the effusion around the heart, the RV anteriorly. Here's the left ventricle, and here's the large mass in this view. And here's just one measurement of a couple orthogonal planes, close to 3 by 4 centimeters in diameter. And another view, sorry, the spine is up at the moment, so there's artifact, but again, you can see that this large mass is in fact greater in diameter, at least in this plane, than the heart itself and its immediate adjacent compression to the anterior superior part of the right heart. Here's a sagittal plane, and this is interesting because here you can see kind of a modified candy cane or arch view with the maybe transverse arch or part of the ductus, the descending aorta, some brachiocephalic vessels arising here, and the mass. And, I had some concern that the direct impingement of this portion of the mass anteriorly to the heart and the very proximally ascending aorta might be a physiologic issue. But here on the next clip, I have a very zoomed up view of the LVL flow tract and the ascending aorta, and I think you can see that there's low velocity pulsatile flow antegrade into this aorta. So at least on this interrogation, at the moment, it didn't seem like this compression was creating obstruction at that time, of course. And interestingly, despite the very large presence of the mass and compression of the heart, we had reassuring Dopplers and estimates of cardiac function. Here on the upper left is an umbilical arterial tracing. Below the baseline here, you can see the venous tracing without pulsations. And I thought the ductus venosus looked normal. So there was reassurance on this Friday at 28 weeks, and a measured combined cardiac output that was over 500 cc's per kilo per minute of at least stability for the moment. So the first step, as all of us fetal cardiologists undertake, is the difficult conversation of working with the family and reviewing with them what's been confirmed in the diagnosis. So as many of you on the call are going to know, this really looks and smells like a intrapericardial teratoma. But the family doesn't know about this. So the counseling session, of course, has to entertain both a diagnosis and some of the nomenclature and concepts, really prognosis, and an extensive discussion with the family about what we know and what we don't about the natural history of this cardiac tumor. And then the next step was for me to promptly refer them to UCLA MFM consultation and evaluation. This was a patient referred from the outside. So the first thing I did was reach out to Dr. Yalda Afshar, who many of you know and is an esteemed colleague of mine. And within a couple of days, the patient was evaluated. And within probably several days already, evaluation had changed. And that includes, on her and her team's evaluation, really abnormal fetal heart rate tracings with abnormal detection of kind of minimal variability and decelerations. Now the ductus venosus was showing flow reversal. There was really progressive hydropic findings on ultrasound and poly. And so from Friday afternoon to the beginning of the week thereafter, obviously the status of the fetus and well-being have changed, and we obviously elevate our concerns for increasing in utero demise risk and a need to decide what we want to do. So this is a diagram that is in submission and revision for JACC case reports that Yalda and I and one of our senior NICU fellows has put together amongst a few others of us, that kind of lays out how we propose, based on the literature and after we review our case, which is similar to others published, on how one might go about managing the fetal intrapericardial teratoma. So while this is not really at this first branch point where we are, follow my arrow, if you will. So for the teratoma intrapericardial and no hydrops, arguably expectant management and surveillance can ensue, and delivery at term is preferable. I think many would agree you'll never get there, and that's why this diagram exists. And we often talk about how best to manage these delicate patients on a day-to-day basis. In the setting of hydrops, and typically what's going to be a preterm and sometimes remote from term gestation, assessment of fetal hemodynamics, which in the modern era, of course, is something that we have in our toolbox with echocardiography and Doppler assessment and other modalities, unlike 20 and 30 years ago, where we still knew about intrapericardial teratoma and hydrops, but we maybe hadn't established as much some of the markers or surrogates for well-being or not as part of our evaluation. So assessing the hemodynamics, if they're severe, many would argue to move on towards delivery and work on postnatal resection, which has been described a number of times to be pretty successful. If there's hemodynamic compromise preterm and you have the luxury of it not being a severe compromise, there may be some other intermediate options. None of these are, I think, a slam dunk in terms of the way to go, but small published reports suggesting that they're doable, and they include mechanically draining the fluid or placing a shunt for ongoing drainage, And if there's no recumulation, considering that a success and waiting towards near term. But that often may not be the case, or may not be the case for long, in which case you're back to where you started up here in terms of hemodynamic compromise. And then the option becomes, do you have the ability, or do you think it's best to do some form of fetal surgery, perhaps as an exit procedure while on placental bypass, and go from there? A few case reports, and we'll look at one example, have been established successfully. Our decision in this case is not a surprise, given the promptly changing ill status for the fetus, and we decided to move forward towards delivery and a planned surgical resection immediately. This was something we talked about for quite a long time, Yalda and I, and Glenn Van Arsdale, our chief of congenital heart surgery. But we each spoke to friends and colleagues, many of these names you recognize below, at other centers throughout the country, including some centers that have more experience with fetal intervention. And so our decision was both internal and external to not move towards a fetal level intervention for this patient, but to get the baby out and to resect the mass and hopefully relieve the mechanical reasons, presumably, for the fetal heart failure and have success. So this is a slide from the UCLA Ronald Reagan Medical Center. You know, here at UCLA, our Mattel Children's Hospital, and Ronald Reagan UCLA Medical Center are hospital and hospital. And so that has some unique advantages and disadvantages, but one of the advantages is all the operating rooms are in the same place. So what you're looking at here is the patient with the obstetrical and MFM team and anesthesia here. We have a number of neonatal and anesthesia members here. There was almost as many people going out the door and into the hallway, but this is the picture captured in the room. And right next door, literally next door, is a cardiac OR that Dr. Van Arsdale and the anesthesia and perfusion and his operating team was scrubbed, ready, and waiting for the baby to be delivered, to be resuscitated in terms of ABCs on the warmer, and then to be brought over. This baby, while still connected to the placenta but sectioned by Dr. Afshar, looked okay, but as soon as the cord was clamped and this baby made it over here is when, as expected, the baby's compromise immediately started. And so that baby received chest compressions intermittently, went right to the delivery room next door, and immediately underwent sternotomy and surgery. I'm going to show you a brief clip of the actual resection. But before I do that, this is a typical example of what a epicardial echocardiogram, in this case, I think because the baby was so small, we used a hockey stick or a 12-frequency transducer. So if you follow my arrow, this is the heart, obviously, and this is the left and right ventricle. You can see this adjacent right heart compression by the mass, which is here. And you can see that the function doesn't look perfect on either ventricle, and certainly there's obstruction. Part of the reason we looked immediately upon opening was to be able to determine the extent and infiltration of this mass on the surface of the heart and peri-aortic in terms of the coronaries as well, because while it would be nice to resect and debulk everything, I think at least in this patient where it encroached upon the aortic takeoff in the coronaries, it was important not to injure those and to perhaps leave some. This is now a cross-section imaging, so I'm doing the buttons, Glenn's doing the probe scanning, and you can see the LV function qualitatively does not look good. Obviously, loading conditions are all weird anyways, but nonetheless, the same can be said for this right ventricle. And then here's an example a little later during resection of using a hockey stick. If you follow my arrow, this is the aorta almost at the valve level cross-section or en face with the right coronary artery taking off from the right sinus. This is the same position with low velocity color Doppler mapping showing the coronary. And we did this, and you see the mass is partly here to ensure that we were staying away from this delicate coronary structure. Here's a clip of the surgery. This is the mass. You can see that it's larger than the actual heart, which is sitting here in situ on bypass. It's now been removed. So this is a picture of the actual mass here and some of the slides demonstrating the histology. The final measurement was almost 5 by 5 centimeters, about 2 centimeters in a third orthogonal plane. An immature teratoma grade 3, and typical of teratomas, there were different types of cellular findings of tissue represented, including foregut and neuroepithelial tissue. The patient was tested with chromosomal microarray and exome sequencing, and overall was normal, though as I was asking a little bit to Shalagna the other day, the patient does have heterogeneity for an ATM gene variant. The postoperative course went pretty smooth. There was discussion about bringing the baby up to the ICU on ECMO, so for myocardial support, but the prematurity and the blood thinning and the risk of intracranial bleed and stroke, et cetera, were felt to be great enough that we actually thought we could not do that and still have adequate myocardial hemodynamics and perfusion, and that's what happened. The baby came up and was not on ECMO. Miraculously, despite various cardiac infusions as usual, by day of life 12, the baby had weaned off all cardiac infusions and medications. By day of life 18, the baby had weaned off ventilatory support, and at 37 weeks and change, corrected, about day of life 61, was discharged home. This is a short axis view of the baby's left ventricle and right ventricle at about a month after follow-up, and I think you can see qualitatively there's improvement of the LV and RV, maybe not 100%, but getting better. And I just saw this patient last week, and she's now about 8 months uncorrected, and miraculously, this patient has no neurodeficits, no heart failure symptoms. She's not on any medications. Her alpha-fetoprotein surveillance being managed in part due to the tumor type and the long-term risk and the AFP that were elevated originally are normalizing. And look at this. This is as I extracted out her growth chart where she was delivered as described, very small, and then made it all the way up to here now at 8 months, which is really awesome. And if you look at the parasternal short axis on the right or the apical view on the left, you can see both the RV and the LV ejection look a lot better. So no big surprise. This looks and follows the described pattern for pericardial teratoma and intrapericardial teratoma, which is the majority. And like a lot of what we do in congenital heart care, it's rare, but we do see it. And depending on how you describe incidence and frequency, it's the second or third most common tumor. I think most on the call know that rhabdomyomata are the most common. And I would say probably fibroma is the second most common, but I think because of the dramatic presentation in utero, if you get a mid-trimester scan that shows a mass in this area with the effusion, that sometimes it's described as the second most common found during the prenatal period. It's really very commonly seen in the usual spot, which is it's originating from pericardium, kind of around the right AV groove, the right surface, the right aortic, the aortic sulcus and that area. It's usually pretty rapidly growing. It has both cystic and solid components and is heterogeneous by nature of being a germ cell line tumor. So as we learned about way back in medical school or nursing school, that includes the endoderm, mesoderm, and ectoderm tissue. And interestingly, there is really never associations with structural or congenital heart disease. It typically presents in the second and third trimester. So even though it's easy to identify if you see it, and with pattern recognition, categorize it what it probably is, there's not always going to be a scan there if nothing else is suspected. So that's a tricky thing. And In some collection of publications, I think that it's agreed upon that the majority of cases have pericardial effusion, and the large majority of those cases are going to progress to high drops and are really on their way to in utero demise. And in one study by our esteemed professor leading this conference today, Rima, about 58% of neonatal surgeries in a case series of about 30-some patients were described to be successful. And I think Rima and her colleagues published that in '06. So that is a little bit of a prior era, but nonetheless, that's not a perfect outcome, though I think it continues to be a higher number. If you do really a review of what we know in terms of the world experience, it still continues to be based on small cadres of patient volumes, single centers, experience, in that kind of setting. So here's Rima and her colleagues' paper that described, even though 2 case reports, they really did a good review of the literature and described a lot of what I mentioned and what we know. And then Jack Rychik and colleagues a few years ago really did a very nice job describing fetal surgery for a teratoma in the second trimester and successful outcome. They did it a couple times, and they did it with placental bypass. And then in the last couple of years, there's been select cases of very small or preterm babies being delivered and successfully operated on. So again, as far as what we know about data and outcome, it continues to be really based on small things. In the perinatal world, there are ways to drain from a procedural standpoint and infusion, but I think the natural history of where it's going to go and the ill fate of the baby really make it debatable whether time is worth undertaking that or not. I think fetal surgery is an attractive idea, but so many variables need to be considered, not the least of which, not every, in fact, most places are not having the extensive experience that a few centers in the world really have established experience in. And then neonatal surgery, it may not be kind of challenging from a technical part, but still it needs to be shown that it can be done perfectly. This is a case from Jack's paper, and it ended less well than my patient, but otherwise is similar. And so here is at 25 weeks, an example of the large teratoma with a mixed heterogeneous picture on ultrasound, a picture of the mass much bigger than the heart. Here's an en bloc resection of the heart and maybe 3 times as large tumor, and what that teratoma looks like typically by tissue. Now, we're getting down to a few minutes. I think we have the time. I took the liberty of a 1.5-minute video clip from Jack's paper, and let's go ahead and look at this such impressive fetal resection now. There's no volume, but I think you can follow along. So I believe this was done in about 24 weeks, and obviously this is an open approach, and what their goal is to expose the fetal chest. But first they have to get to it. As we're watching them finish getting access, ultimately you're going to see they will do a median sternotomy, debulk the mass, close the sternum, and then put the fetus back. Here's earlier on where they're obtaining fetal intravenous access in order to be able to administer medications. Now the surgeons are undertaking the sternotomy. And then they work on removal. They did publish a second online video that's accessible. I'm going to surpass that for the purpose of time, but I think you get an impression of this really impressive undertaking in a fetus. So for the sake of time, I'm going to move on, and I'm going to go back to Finishing my slides. So in summary, I presented a case this morning in the past year of an intrapericardial teratoma. It had a lot of features that are described that we've seen with intrapericardial teratomas, but it doesn't mean it makes it easy to know exactly what and when to do. So while it is rare, it does happen, and it's important to kind of highlight that. I presented some of the case details, including progressive high drops and a very real risk of losing the fetus, and thus a need to discuss with multiple people, the family, my colleagues, experts elsewhere, on how we think the risk benefit falls. We chose to go towards the neonatal deliver and neonatal resection. I think if nothing else, both with family members and ourselves and others, communication and honest discussion about all the variables and covariables are important. This is not, last week when I saw the baby, but this is the baby a few months later looking beautiful. And for those of you that know Glenn Van Arsdale, our surgeon, this is a great shot outside my clinic of Glenn holding the baby, which is really a nice picture. And really, we are so thankful to have a surgical team that can provide this option for us and the family, and we all appreciate that. Thank you very much.
Thank you so much, Gary. Beautiful talk, and I just, if you'd allow me to go with you on a few educational points in this case. Now, the teratoma in the ultrasound, we most probably it is because of what? Because of the appearance, the location, for the differential. If someone is faced with such a tumor, what would you look at? The position, you said, as you said, it's on the right side, the presence of skin, and the multiple echo dense areas in the mass. Anything else that you like give a hint to others who are scanning such a case?
Yeah, I think for the fetal scanner, we usually describe the count. So is there one lesion or more? I think if there's more than one, we almost universally infer that it's rhabdomyomas. If it's only one, it may be a rhabdo, maybe a fibroma, maybe something else. Is it ventricular? Is it atrial? Is it intramural? I think in the case of intrapericardial space, while it could be a very, very rare hemangioma or something else, that it would probably be a teratoma until proven otherwise. I think the size can affect how much, if any, heart failure or hemodynamic compromise is present, and all the standard fetal echocardiographic interrogations in terms of Doppler and maybe myocardial deformation and lots of different tools in our toolbox we can use to determine that, along with MFM evaluation and antenatal surveillance to decide when, if we need at all, to go in, because as many of you know, most of our patients, we don't have to intervene preterm. We just don't. Even impressive intracardiac masses that look like they may have ductal dependent obstruction may not, once they're a neonate and delivered and evaluated. So yes, count, location, appearance, tissue characterization. We didn't talk about it because it's a intrapericardial teratoma, but as many know, cardiac MRI was well described and is well utilized in this day in the newborn period or the neonatal period to often help tissue characterize a neonatal cardiac mass or masses. And so we will do that a lot, but it didn't play a role here.
And also, it's very amazing. The baby presented at, I think, mid-trimester, right? The second trimester.
Yeah, my understanding is it was a routine growth scan. So the family and we all were so fortunate that our community MFM scanned the patient, and even if they're not cardiac experts, they obviously identified the very large mass and very promptly reached out and asked us to evaluate the patient and go on from there.
I just want to ask the audience if they have any questions, put on the Q&A, and we'll be very happy to answer. Anybody from the panel have questions for Dr. Satu?
Hi, Rima. Yes, I have a question. It's about monitoring. So from when they found the mass, how often were they following up this patient? Was it weekly? And what kind of monitoring they were doing? So
this patient developed There was obviously a large effusion and somewhat reassuring Doppler indices the first day I saw the patient, which are the images you saw. I only saw that patient that once. Why? Because progressive high drops developed within days. So there was no long-term surveillance. That patient got admitted. We immediately discussed what we wanted to do. We went back and forth on the merits of prompt delivery and neonatal resection versus a fetal intervention, et cetera. And we chose to deliver and operate. So there was a very short period, but it included the MFM inpatient team doing antenatal evaluation and ultrasound, and included the original fetal cardiac imaging from my perspective. But I think your question might be more so in other similar patients you encounter. How would you know how frequent to follow? Do you do it inpatient? Do you do it outpatient? To what degree? And I think the question's a good one without completely clear-cut answers, but I think more and very frequent is the answer. So I don't think there's any downside to doing it under a observed inpatient environment, at least for a period of time, because you may need to rally the troops and decide to move towards delivery promptly. It really depends how preterm you are, what your resources are at your institution, et cetera.
I just want to add one thing regarding the follow-up. It depends where you're practicing, and if the patient can come as outpatient or not. It's as you said, Gary. It's very important that with days change completely from normal doctors, probably a sort of a relative tamponade. So, if you are in a place where you have a team, yes, it can be managed as an outpatient, but not admit and up. I remember the cases that we reviewed. One of them had a shunt. Dr. Did we put a shunt from the pleura, and the baby survived, and the function was fine at that time. But I think, Gary, in your case, it was very bad. I mean, in a way, it was really a huge mass, and you didn't have much time to do a lot, right?
Yeah, I think that's right. I think, listen, the baby was 28 to near 29 weeks. If this was 24 weeks, that might have been a problem, and we might have gone in a different direction. But the degree of hemodynamic compromise and its promptness and being at least 28 to 29 weeks, I think you mix that all together, and that's what made us feel like probably the best approach for survival was just to get the baby out and take this thing out, decompress the adjacent tamponade, and go from there.
Also, there is when you talked about the fetal surgery, as you said, you sort of very critically discussed the case. Are we going to go or not? Baby is stable, the fetus is stable. There was I think a resection of a, and the beauty, I think, of this case is that it has a sort of a membrane around it, so you take it in total when the surgeon goes in. Right, probably. I mean, you try. That makes it easier than other lesions. Was this the case?
Not exactly. According to Glenn and what the team described as we were doing this and what we could see on imaging, the anterior superior portion on the right heart was attached enough that residual tumor mass did have to be left a little bit around the takeoff of the coronary and near the aortic sulcus. So it debulked relatively easy. I'm not the surgeon, so I'm kind of speaking on their behalf, but purposely we left a little bit. And that's a small part of what I think is the idea about following AFPs and having our oncology team, in addition to our genetics team, continue to follow the patient for long-term, surveillance and excellent survivorship. But the general data in terms of adult cancer risk, while not zero, is pretty low.
And you've done the genetics of the mass and the genetics of the baby. Did I get this right?
Yeah, I mean, I think Shulagna, I don't know if you have a minute to chime in. The ATM gene is like ataxia-telangiectasia, and it has some affiliation, I guess, with that. But basically, I think there's a small risk of cancers. Is that the deal?
So not my case, but what was found was that there was a heterozygous mutation. So not in both copies of the ATM gene, which is typical to lead to ataxia-telangiectasia. Instead, there was a single mutation, and that is associated with adult onset cancers at a enhanced, but not highly significant risk. And they were counseled
in the mass or the baby? Just the mass or the baby?
In the baby.
The baby. Do we do
And again,
any
Rima,
genetics?
you guys, this is, I know for us old people, this is no surprise, but, for the younger people and trainees on the call, I mean, 20 years ago, correct me if I'm wrong, but I think 20 years ago, we knew a lot about the presentation of pericardial teratoma, but the DNA analysis wasn't quite as advanced as it is today. So I think we have the luxury of long-term surveillance from lots of patients in different ways that the technology has allowed us to follow and smartly follow more than we would think about or do in the past, perhaps.
We have a question from the audience. Says, is there a place for fetal biopsy?
Oh, well,
Or
the
a mass?
tissue, the tissue was sent off, and that slide I showed with the a sample of a couple slides, that's exactly the description of the of at least ours. The question is, does someone mean, is it worth biopsying in a semi-closed fetal environment and leaving the fetus in situ if you actually get the right tissue and the tissue is non-threatening? Is that the question?
I think so, yeah.
Yeah. My guess is probably not, because I think the odds are going to be 98, 99% teratoma, and the large majority of those teratomas, you're going to treat them based on, I think, demise risk and prediction of more than tissue characterization. And I can't speak towards the risk of fetal tumor biopsy. I would have to defer to a procedural MFM or a pediatric fetal surgeon, but I would think that alone, just like an amnio, but more invasive, has to be considered as well.
I don't think it's usual. Is Yelda with us in MFM? Yelda, are you with us?
Hi, yeah, I'm actually in a bad reception, but yeah, so I think in terms of the fetal biopsy, it is a very high risk procedure, definitely not like an amnio, because we're actually then going into the fetus, into the heart. I think the risk benefit, I agree with Gary, not recommended.
I haven't heard of anyone doing it, actually.
There are actually case reports, not with cardiac, but there are intra-abdominal biopsies that have been done
Yeah,
to
even
determine
postnatal.
viability.
Even in children, if you have a tumor, very unlikely that you go for a biopsy with an MRI and whatever we have nowadays, isn't it, Gary? You go for like if you have a child with a mass and stuff like that. Do we go for needle biopsies or whatever, mass biopsy postnatal for cardiac cases? I don't think it's common.
Yeah, I think you're right. In the general care of fetal and neonatal tumors, if you're asking in that specific group, it's pretty uncommon. If you end up operating to relieve obstruction from some hemodynamic reason, then obviously the tissue always gets sent. But I think that it's pretty uncommon, probably very, very uncommon, that people choose to, in a closed or semi-closed environment, get tissue characterization, decide what to do. I think we're at a point where we know most of the time about rhabdomyomata because we have been testing for TSC, and so that can help confirm. And we know they're going to get smaller over time. And so unless in the newborn they're really ductal dependent obstruction, let's say the systemic or pulmonary arterial blood flow or something like that, no matter how big and impressive they are, often you're just not going to need to do that. And, other things like fibromas and other lesions that create ventricular tachycardia, somewhat untreatable or intractable arrhythmias. The Boston group and others have described that it's probably best to take the mass out and to reduce the arrhythmia burden and fix that. And I think most people agree with that approach. But I'm not real familiar with biopsies having a role by and large in this population.
Thank you so much, Gary. And for the sake of time, we'll move to our next speaker. And it's my honor and pleasure to present our clinical geneticist who's going to introduce herself.
Yes, good morning. I'm Dr. Shalagna Saita, and are you able to see my slides?
Yes.
Okay. I am a pediatric clinical geneticist, and I not only work in the pediatric space, but I also help support our MFM team here. So today, what I'd like to talk about is the more of the approach of genetic testing in the face of congenital heart defects during fetal life and into neonatal life. Let me see if I can get the right view up. Okay. Here we go. So no disclosures. So as this group well knows, this is one of the most commonly found birth defects, and a significant proportion requires surgical intervention in the neonatal period. So having this identified ahead of time is often very helpful, and especially in cases where you may not have an isolated congenital heart defect, but maybe part of a syndrome. And rapidly, genetic testing has become a mainstay of part of the diagnostic process. And what we used to do even 3 years ago in the neonatal period has now shifted into the prenatal period. So either isolated cardiac defects or syndromic cardiac defects can be caused by genetic mutations. And the genetic cause was identified in about 20 to 30% of cases. And this is from 2015, before the advent of just rapid access to next generation sequencing types of testing. So that number is probably now closer to 30 to 40%. And this is the front line. Often fetal echocardiogram is the very first indication that the fetus actually has an underlying genetic disorder. So in terms of the prenatal evaluation that often can lead to fetal echocardiogram, we in the past have all grown up with a first trimester analyte screen, and this has rapidly shifted. And here in California, we've moved entirely to cell-free fetal DNA analysis just over this past year. In addition, what's very helpful is the nuchal translucency measurement and the anatomy scan at 20 weeks. And often these are several points that prompt an investigation further by a fetal echocardiogram. So I want to talk briefly about the increased nuchal translucency. And this is done by OBGYNs, usually in the very first trimester, around weeks 9 to 13. And again, you're measuring the thickness of a fluid collection in the back of the fetus's neck. And an increased thickness is greater than 3 millimeters. And this in and of itself is a risk factor for fetal anomalies, which then prompts someone to look further, often a referral to an MFM. And some of the most frequently encountered syndromes that you see with increased nuchal translucency include Down syndrome, Turner syndrome, and Noonan syndrome. And we'll talk a little bit about these more later. But as you can see, all of them are well known to be associated with congenital heart defects. In addition, even without the syndromic features, sometimes the nuchal translucency is the first time that will lead to investigation of an isolated heart defect. You can also have an increase with other physical defects, such as an abdominal wall defect, as well as some types of skeletal defects. And a large, extensive nuchal translucency that might have septations within it is referred to as a cystic hygroma, and that significantly increases risk of having an underlying genetic disorder, particularly in a female fetus, Turner syndrome. I want to talk a little bit about the rapid adoption of what we're changing the nomenclature a little bit. So we're not necessarily calling the non-invasive prenatal screen. The American College of Medical Genetics now refers to this as cell-free fetal DNA screening, just to sort of define exactly what's being done. And remember, this is a screen, not a test. So what's happening is in the first trimester, there is fetal cell-free DNA, and that's circulating in the mother's peripheral blood. And it's sequenced, and this is typically based as a screen for Down syndrome and has expanded to other chromosomal anomalies and some microdeletion syndromes with variable accuracy. The cell-free DNA is present in the maternal circulation, is detectable from about 5 weeks, but is at a high enough volume that it can be reliably tested after about 10 weeks. It's cleared from circulation within 30 minutes of delivery, and it originates from trophoblasts, or the developing placenta. This is significantly smaller than maternal DNA. These are fragments that are about 150 base pairs. So they're sort of chopped up, shredded DNA. And the concept is that you can separate this away from the maternal DNA. And therefore, you're able to isolate it, sequence it, and get an idea of the copy number. One caveat here that we've seen is that increased maternal BMIs can decrease the accuracy of this screen. So I want to talk a little bit about performance because we get these questions all the time. And remember that the goal here for the screening is to try to reassure the patient. So up until recently, we used combined first trimester screening, which was the analyte screen, and the performance was an 84 to 90% sensitivity with a 5% false positive rate. When we've switched for Down syndrome over to cell-free DNA, that's now giving us a 99.7% detection rate with less than a 0.5% false positive rate, which is exceptional. And this is the reason for essentially switching over. When we look at the assay itself, the test itself, it has quite a good set of parameters. And this is from a website of one of the major companies that tests. And you can see that the sensitivity and the specificity across many of these well-known trisomies or disorders is actually quite good. But remember that the sensitivity calculations that is done in the laboratory setting, and they're usually using a positive sample, so DNA from a patient that has one of these disorders, and diluting it down and then determining whether or not it can be picked up. And that's what those calculations are based on. This is not a real world analysis in the general population. And there's a couple of principles that we need to keep in mind. One is that chromosomal anomalies, like entire trisomies, increase with maternal age. And that has to do with the mechanism of being able to separate chromosomes. And this starts to take off at about age 35. However, microdeletion syndromes, and we'll talk a little bit about DeGeorge syndrome and 22q deletion, that actually does not increase with maternal age. So some of the algorithms are based on an increase in frequency with maternal age effects, which again, relevant for the trisomies, not as relevant for the microdeletion syndromes. So what do? One important thing that we and the prenatal genetic counselors do is we look at the positive predictive value of these screening tests. So this is the proportion of samples that are testing positive that are truly positive in the population. And the positive predictive value is actually higher when the disease is more prevalent. So let's run through what this is. So the cell-free DNA screen, again, is better for positive predictive value when the disease is more prevalent. And there's a very nice calculator that is on the website of the National Society of Genetic Counseling that goes into this. And it tries to answer the question of this: if my test is positive, what is the chance that my baby is really affected? So what we need to remember is that if you're 20 years old or if you're 40 years old, it's exactly the same test. And that assay has the same sensitivity and specificity. That has to do with the test. However, if you get a positive Down syndrome screen, it is way more likely to truly be positive in your 40-year-old than it is in the 20-year-old. And that's what we're looking at. So using this calculator, I just did an example at 16 weeks gestation. What is the positive predictive value for cell-free DNA testing in a 35-year-old versus a 32-year-old, which is often what we encounter. So for trisomy 21 or Down syndrome, 79%. At 32, it goes down to 68%. So you have a 32% false positive rate. This starts to worsen for the other trisomies. So trisomy 18, considered a fatal condition, 39% positive predictive value because it's just not that prevalent in the general population, and 27% in a 32-year-old. And this drops again with trisomy 13. The sex chromosomes, actually not much better. I just looked at Turner syndrome and it's 41%. And 22q deletion, which is something that I work on myself, had a pretty abysmal positive predictive value of 19%. There's a recent paper out where one of the companies using AI technology has gotten it up to 50%. But I will say, as a geneticist, when you're dealing with these percentages that are close to the accuracy of a coin flip, we don't find that reassuring for our patients. And for those reasons, the Society for Maternal Fetal Medicine and ACOG and the American College of Medical Genetics has actually not endorsed checking off the boxes for doing microdeletions and limiting cell-free DNA screening to just the trisomies at this point. I know that the vendors are actively working on on technological fixes that will help with better sequencing and also using better algorithms, which hopefully will improve this. So the bottom line, cell-free DNA is quite reliable to pick up Down syndrome, but for the other disorders, we don't across the board consider it accurate enough to actually reassure the patient. So what's the answer here? And that is to actually offer diagnostic testing. So prenatal diagnostic testing, the same methods, CVS from chorionic villus, which also comes from the trophoblast at 11 to 13 weeks, or from the fetus itself later on at 16 to 18 weeks. And there are multiple tests that can be run on the DNA that's extracted from these samples. So as we've all grown up with is the karyotype, aneuploidy fish or specific fish that you indicate, such as 22q, a microarray. Perhaps you're looking for a single gene that's known to run in the family, panel testing, or fetal exome testing. The karyotype, well-established technique. It's been around since the 60s. All of the variants are known. This is still the only structural analysis that we have where you can actually look and see if there's a translocation or an inversion. The disadvantages are that you have to be able to see it under the microscope, and the resolution is pretty low. You need about 10 million base pairs to be missing or extra in order to see it. And you need to culture the cells, and it takes about 7 to 10 days. There are still several disorders where karyotype really kind of is the gold standard, Down syndrome or trisomy 21. And I've just listed some of the prompting cardiac defects that might lead to the amniocentesis. So presence of ASD, VSD, less commonly tetralogy of Fallot. Trisomy 18, very variable, all over the place in terms of what the congenital heart defect might be, including some valvar dysplasias. Trisomy 13, also variable, but we think of trisomy 13 as more of a midline defect. So you do sometimes see laterality defects with trisomy 13. And then Turner syndrome, think of left-sided lesions. So BAV, hypoplastic left heart, most commonly if it's a female fetus with hypoplastic left heart, I'm thinking Turner syndrome is top of my differential. These, however, are syndromic presentations, and they're also likely to be accompanied by other congenital anomalies and fetal growth restriction. And these are recognizable patterns to the maternal fetal medicine specialist. So we work hand in hand with them. I want to talk about fish. There's a lot of, I guess, investment and love for fish, but it really is, it is sort of a diminishing role as we're moving forward. This was developed in the 1990s, and what you're actually doing is taking a piece of DNA that you know where it maps to, labeling it with a fluorescent tag, and having it go to hybridize to its chromosome. And it's not a structural analysis. It just tells you how many copies are there. So here you see 2 copies of this locus and only 1 here. It's a fast, quick check to look for all 3 trisomies. You're expecting 2 dots, you have 3, and you can do that simultaneously. It's fast in 2 to 3 days. You don't need to culture the cells, but you won't be able to tell, for example, is there a translocation causing Down syndrome? It'll just tell you that there's 3 copies. And the other disadvantage is that if you want to look at something other than 13, 18, or 21, you need to specify which chromosome to test ahead of time. So this is hand done and not automated. So this often takes longer and ends up long-term being costlier. I'm from Philadelphia, and I actually trained very early in my career with Dr. DeGeorge, so I have to take a minute and talk about this. So back in 1965, Dr. DeGeorge, who was an endocrinologist, and Dr. Lishner, an immunologist, described a syndrome that is well known to most of you, that was composed of a triad of conotruncal heart defects, typically tetralogy of Fallot or interrupted aortic arch, hypoparathyroidism that resulted from usually aplasia of the parathyroid glands, and thymic aplasia or hypoplasia that led to usually life-threatening or life-limiting infections. And we have been able to pretty much fix all of these over the last few decades. Back in 1993, there was a development of a FISH probe, and that showed that DiGeorge syndrome actually was caused by a deletion in one of the two copies of chromosome 22q near the pericentromeric region. So just below the centromere is the Q11 region, and one of the copies of the chromosome has a deletion that takes out a dose of about 50 genes. Later on, another group that was studying what they thought was a different disorder called velocardiofacial syndrome, velo meaning palate defects, outflow tract defects, and differences in the facies, was also found to be caused by the same deletion. So they are one and the same. You will hear mainly cardiologists and immunologists referring to it as DiGeorge syndrome, whereas the palate surgeons will call it velocardiofacial syndrome, but we've taught parents to call it 22q11 deletion syndrome. And that's the term that the geneticists will use. This is one of the original FISH, so it's sort of a historic slide. And you can see that the bottom of chromosome 22q here is labeled with a green fluorescent probe, and the Q11 region with a red one. And you can clearly see that there's one signal here, but it's missing on this chromosome 22. When you do FISH in the interphase where the chromosomes are not spread out, you can rapidly count and you're missing that second red. That implies that there's a deletion. So this is the most common microdeletion syndrome, and the incidence of 1 in 3,000 live births. In your practice, you're going to see mainly conotruncal cardiac defects. What is interesting about this is not only its high frequency, but that the majority of these are de novo, or where the patient is the first person in the family to have this. About 10% are passed from an affected parent. And as you might guess, 40 years ago or 30 years ago, because the cardiac surgery wasn't as advanced, many of those children didn't go on to survive and have their own children. So many affected parents don't have a structural cardiac defect. It could be subclinical, such as a right-sided aortic arch. So sometimes they are not diagnosed until they have an affected child. This high rate of de novo deletions happening over and over, and I should mention it's the same size deletion in most people. This is related to the structure of the chromosome. This is also the most frequent syndromic cause of palate defects, and it's a pretty significant factor in children born with congenital heart disease, particularly, again, focused on conotruncal outflow tract defects. And the common ones are interrupted aortic arch type B, tetralgia Fallot with pulmonic atresia. There's a 100-fold enrichment for persistent truncus arteriosus, especially the type 2, and aortic arch anomalies. What I just described is considered a genomic disorder, and it and several others across the genome, microdeletions where you're removing a dose, or microduplications where you're adding a dose of developmental genes, are the underlying cause of a significant proportion of genetic disease that we see. And again, this is a change in copy number and loss or gain of the correct balance of those genes that are needed for proper development. Remember that these are too small to see under the microscope. You will not pick them up with a karyotype, and they are known to present with congenital heart defects. And I just listed a couple of the more well-known or common ones. This one we've talked about already. 1p36 deletion is actually 1 in 6,000, so it's actually second to DiGeorge. It has variable size deletions, and it typically presents with cardiomyopathy or non-compaction. And this can be seen quite early, and there are also septal defects that have been seen. And then 7q11.2 deletion is associated with Williams syndrome, and that is usually supravalvular aortic stenosis, also pulmonic stenosis, and PPS. So we thought, what if you could take all of these different FISH probes and put them all together? And one of the things that happened that helped this process was sequencing the human genome. And so we took all of those pieces from the human genome sequence and arrayed them on a slide. And that's where the word microarray comes from. So the way that I tell it to patients is think about your USB drive, whereas maybe before you would have like 1 meg of bytes on there. And now it's up over 64 gigs. So you're putting more and more probes on there. So these are the different terms that are used. It was originally called comparative genome hybridization, or CGH. Sometimes people will call it a SNP array, but the correct term is actually chromosomal microarray, or CMA. And we use now 2.6 million probes across the entire genome. So we get pretty high resolution for pieces that are missing or extra, and it tells us what the gene content is as well. So the significant advantages are that you can see things that you would not pick up under the microscope. So submicroscopic chromosome deletions and duplications. And because it's genome wide and it's automated and highly reproducible, it costs less than doing fish after fish. And you also don't have to decide in advance which region to look at. So think about, especially in the prenatal setting, you can't go in there and say, okay, fish chromosome 22, oh, it's not that. Fish chromosome 7, each one of those takes 3 to 4 days to do. So this is one test that takes, usually the turnaround times are about 7 to 10 days. This is the principle behind chromosome microarray. The test DNA, which would be in this case DNA extracted from an amniocentesis, or a CVS, is labeled with a green dye. And then on the plate is the reference genome, which is labeled with a red dye. And when those match up in terms of dosages, it turns yellow. Here's a case where there's not enough test DNA, so the red overpowers the green, and therefore that shows up as a deletion of these loci. And this is the actual output. This is one single chromosome, and each one of these dots is a probe. So we look at the ratio, and this is right at the 0 line. This is where this is normal for 2 copies of all of these genes. Here, this is off the baseline and above. So this is a duplication. And instead here, it's below the baseline, and that would be a deletion. And this track is following the allele frequency. So you can see that it should be 3 lines here, and you can see that 1 dropped out in a deletion, and here you've added 1 for a duplication. So it's a very high resolution. And now this has been around since 2006. So we've really seen a lot of variants. It used to have 10 to 25% of the time a variant of uncertain significance, and that has really gone away. And I see that now less than 1 in 20 patients where we have to do follow-up. So fish versus chromosome microarray, are the arrays better? Well, you get all of the known deletions and duplications done at once. You get 136 different deletion and duplication known syndromes done simultaneously. So that makes it, because it's automated, it's cost-effective, highly reproducible, and faster. And is the detection better than fish? And the answer is yes. I just want to, for this audience, talk again about chromosome 22. This is chromosome 22 on its side, and these are just structural markers that are on the chromosome itself. And this here, this black bar, is the typical deletion. So it goes from here, A to D. The fish probes that have been developed and have been used forever are located right here. So we were picking up about 79 to 80% of kids that we thought had 22q deletion. But once we had the advent of chromosome microarray technology, we started to see, wait a minute, we're missing every deletion that starts down here. So the majority, about 80%, are in here, but these are 4 of my patients, and they were all missed by fish, and they all had persistent truncus arteriosus type 2. So there is a significant proportion, we're going to say 15 to 20% of patients who will have a 22q deletion that will be missed if you just use fish alone. So this statement came out from the American College of Medical Genetics and the American Society of Human Genetics back in 2010, where the white paper determined that chromosomal microarray should be considered as the first-tier clinical diagnostic test for unexplained developmental disabilities or congenital anomalies. And it will stay that way most likely until we really move to an era of whole genome sequencing, which is hopefully right around the corner. There are some limitations for chromosome microarrays. And remember, it is not looking for a mutation inside a single gene. And that's often a misconception with parents and even some providers. This is what it's doing. Here's 2 chromosomes, chromosome 1 and the other chromosome 1, for example. And what it's picking up is the fact that there's a deletion in here that you're missing these 3 genes. That's what an array does. But we know that there are single gene disorders that explain some of our prenatal cardiac findings. And what we use is a completely different technique to pick these up. The single gene disorders, we use sequencing. And sequencing modalities have really gotten very, very good, especially in the last 10 years. And these will look at single letter changes. And we know that there are single genes associated with both syndromic cardiac lesions as well as isolated cardiac lesions or non-syndromic ones. So what you're doing is looking for a mutation or a single letter change within a gene. So here I've outlined that this C changes to a T. That then changes the amino acid sequence. Sometimes it truncates it and affects the product of that gene. And most of the genes that we're looking at are needed developmentally for the heart to form properly. And there's two ways that you can do a sequencing-based test, again, from the DNA that you would get prenatally. You can do a panel of known genes that it's curated. So for example, if you wanted to do a set of genes that looks for Noonan syndrome or hypertrophic cardiomyopathy, this could be done rapidly. Those are not updated usually even every year. It's every 2 years. So it may not have the latest genes that would be added on there. But it will do a very good job of all of the known genes. And most of the times, these panels are updated every 2 to 3 years. Or an exome where you don't know what you're necessarily looking for, and you're just going to sequence every single gene. There's some downsides to that, as many of you have encountered when you do exome analysis, and those are called variants of uncertain significance. So you often get back stuff that you cannot resolve, and that can often add to increased anxiety, not only for the patient and their family, but also for the physicians. So what are we testing for when we're looking at sequencing-based testing? We're looking for single gene disorders that have prenatal cardiac findings. And here's a list of them that many of you know quite well. The RAS-MAPK pathway genes, and they include multiple syndromes that often present with prenatal cardiac findings. Noonan syndrome is one of these genes. What we used to call leopard syndrome, now referred to as multiple antigenies. Costello cardiofaciocutaneous, and these are very dramatic. These are the ones that you think about presenting with high drops, dysplastic PVS, or hypertrophic cardiomyopathy and arrhythmias. And we looked at a whole collection of patients with non-reentrant atrial tachycardia that presented in fetal life, usually in the mid third trimester, and they all had findings with these genes. Charge syndrome, which actually mimics 22q, conotruncal defects. So you see quite a few interrupted aortic arch, tetralogy, double outlet right ventricle, and septal defects as well. Heterotaxy genes, and these can come with or without abdominal situs issues. A lesser known, but one of the ones that's really associated with HLHS, and in general, hypoplastic left heart has a lower yield unless it's syndromic in terms of finding a genetic reason for this. But for left-sided lesions, hypoplastic left heart, this is one of the genes, two of the genes, and Rubinstein-Taybi is a syndrome, as is Kabuki syndrome. We've seen a recent little cluster of, I think, 4 patients with Schoen's complex that all had Kabuki syndrome, but also associated with hypoplastic left heart. And Alagille syndrome, there's 2 known genes, and this is often long before you'll see in neonatal life, the liver problems. You can sometimes find the aortic stenosis, pulmonic stenosis, or the tetralogy that is associated with this. So remember that these will not be picked up on a chromosomal microarray. You need to specifically look for these single letter changes in sequence, either using a curated panel if you're suspicious of one of these disorders, or an exome. This is a reference that I really like. It was originally done, and it's published in Circulation. It was originally done in 2007 and was updated in 2018. And it really has beautiful charts that prompt what the associated cardiac finding is with the genetic defect. So I did send out a couple of questions. I'm just going to run through these if that's okay. Is that all right, Rima, for me to do the 2 questions?
Sure, we're enjoying. Thank you so much.
Okay, so case 1 is and I just have 2 cases. So it's a 34-year-old G1P0 woman who presents with an increased nuchal translucency, and the cell-free DNA screen was negative. So an amniocentesis was done, and karyotype was done, and the trisomy fish, and that showed a normal male complement of chromosomes. The fetal echo was then done that showed an ASD, pulmonic stenosis, and LVH. Over the course, and this is one of my patients actually, over the fetal course, there was polyhydramnios, pericardial and pleural effusions, and then multifocal atrial tachycardia that started at 32 weeks. So my question to the group is, what is the next best test? I think you have in your mind what this might be, and what would be your next test that didn't get done yet. These are all tests that have not been done. Chromosome microarray, an arrhythmia gene panel, 22q FISH, or a RAS-MAPK Noonan gene panel. So this baby was delivered at 35 weeks, which often happens with this group of patients, and had significant multifocal atrial tachycardia that ultimately responded to flecainide. On exam, the baby had low set ears and high drops. And a DNA panel for Noonan spectrum disorders was sent. And the answer here was PTPN11, which is known to actually have a 50% association with pulmonic stenosis. Exome sequencing would also have detected this, but that takes a little bit longer to come back because you're looking at the working parts of all 23,000 genes, and you also may get back variants of unknown significance. And the cardiologists and the neonatologists and all of us really thought that this is going to be this, so we sent off a panel. And many cardiomyopathy panels, so there are curated panels for hypertrophic cardiomyopathy. Many of them will include the set of genes, but not all of them, and it varies from lab to lab. So this is where you enlist your geneticists and ask them, like, am I sending this to the right place? Does it answer the question that I'm asking? And the last case is a 30-year-old G1P0 female who presents with a 24-week male fetus with supravalvular aortic stenosis, pulmonary stenosis, and fetal growth restriction. The evaluation had included normal cell-free DNA on the screen, a normal karyotype, normal trisomy FISH, XY FISH was done, and a 22q FISH was also done, and a normal Noonan gene panel. So what's the next best test? Chromosomal, remember that we still have, when you do amniocentesis, there's always DNA remaining from that. So we can still continue to add tests on within the scope of the pregnancy. Whoops. So chromosomal microarray for microdeletions, whole exome sequencing, methylation testing for Russell-Silver syndrome, given the fetal growth restriction, or did you just miss something and you need to go back and do more FISH counts for looking for mosaicism? So I'll let you think about that, but the key here is going to be what the cardiac findings are. So this answer actually is chromosomal microarray, because what I presented here was a case of Williams syndrome, and it's a 7q11.2 deletion. So you would not have picked it up with these individual fishes that you did, and it's not Noonan syndrome, going a very specific panel. So in such cases, we usually go with a chromosomal microarray first and then move on to sequencing. And there are ways that labs can expedite these in prenatal cases. So I'd like to thank, as you all know, it takes a village to take care of patients like this. And I'd like to thank our prenatal genetics team, our erstwhile MFM colleague, Dr. Afshar, who's been invaluable, our fetal echocardiology team, and our neonatologists. So thank you for your attention.
Shogana, thank you so much. Such an informative talk, and you asked two difficult questions for us. The cases that you've shown, very, very nice. And if you allow me to go back to the last two cases and think of what test together we want to do. The first case, this one, the first, what you said, well, I understood that that the microarray solved most of the problems. Is this correct?
The microarray will not solve the problem because this is Noonan syndrome, and it is
no, generally genetic testing.
Oh,
you said microarray is better than FISH. Microarray,
absolutely.
Yes, everything is cost effective, time effective. So for us as cardiologists or pathologists, we would think of microarray as number one in any, and then we go into the details of the case. So this is one approach. Next.
Yes. So I had the main reason that I would look at this a little bit differently, but yes, most of the times the microarray is going to get done right away. It'll be done with a karyotype and a microarray instead of FISH. And that is what happens in our institution. When we look closer at what we're dealing with, at the time, it's these effusions, not having other structural anomalies like a cleft palate or club feet. It's really about the pulmonic stenosis and this. And if you look at the course, and I'm trying to remember, I think this was maybe at 24 weeks. And here, as the course proceeded, and Yalda will also let you know, it was the multifocal atrial tachycardia and the developing HCM and high drops that really set us off on the Noonan spectrum. And that's classical. And often this is one of the ones that you will pick up even very early on. It'll be in the back of your mind, wait a minute, that NT was really large. And that might have been the very first sign. So people are already sort of looking for this, and the MFMs, as they start to see something like this evolve, will often bring the patients in weekly just to monitor for the evolving high drops. And these patients are often delivered early, usually 34 to 35 weeks.
I don't have the knowledge, and I'm just picked on what test. I didn't have anyone with me in the clinic. I didn't have any contact, or I don't have a staff, and I ticked on microarray. Where will that take me in this case?
It'll be normal.
It will be normal. So here, the phenotype is very important. Now we go into the clinical details of the fetus. That would, and when you say DNA panel for Noonan syndrome, when I was taught genetics, I understood that what you showed that is what we already have as our school, the teacher used to say, in the cupboard. So these are already genes that identified for. There could be other genes that we don't know yet, right? Or as you said, it could be updated all the time.
Right. So this is, I think at the time that this was done, this is a couple of years, maybe 4 years ago, this is what, about 13 genes. Now it's at about 17. So I don't see LZTR on here or RIT1. Oh, it's on here. So there haven't been many more that were added. I think Bruce Gelb has done a great job of identifying, and Amy Roberts actually of identifying most of the genes that are associated with this phenotype. We're not getting significant ones later, but the key ones, and especially with pulmonic stenosis, you're really looking at this gene and with the tachycardia.
To go with, if Yalda stood there, probably with the NT, and probably it was a cystic hygroma or just an increased NT, and the cardiomyopathy. Gary, you would agree? I'm not sure if the tachycardia antenatally is part of the Noonan spectrum, but I know that cardiomyopathy and the increased NT and the cystic hygroma, and probably the arrhythmia. I'm not sure if arrhythmia is frequently seen antenatally with Noonans. Is this?
Yeah, so actually Angela Lynn published a series a few years ago with using some of these patients, and it was non-reentrant atrial tachycardia.
That's very interesting. And you wrote exome sequence it would have. So for lay people like me, I would say, okay, I've learned the lesson today. I'm going to do microarray if I have. I'm not very good in genetics. I don't have anyone with me. But the next step, if it's available, exome sequencing. Is this correct?
So here, most places, the panel is going to be easier to send than exome sequencing. The issue with exome sequencing is it's not as accessible for everybody, especially in the prenatal and inpatient setting. It takes longer. And you do have these, because you're doing everything, you can come back with things that you weren't looking for, you didn't ask about, and they're variants of uncertain significance. And then what you have to do is look in the parents and then see if, oh, okay, maybe we can get rid of this, but it becomes extremely stressful during a pregnancy to have to go through that process.
So much, it's beautiful. Any questions from the panel? I have a few questions from the audience. Gary, do you want to comment?
No. I mean, I was going to ask Shalagna, what's the turnaround time on a panel these days?
So in the outpatient setting, depending on where you send it, it's 3 to 4 weeks. Inpatient, if we're sending it out, it's often about, we can get them to do it in 7 to 10 days. In-house exome for the people who have the luxury of having that will be faster. And there are rapid genomes. So what happens with rapid genome, there are companies that will tell you that they'll give you a prelim in 7 days. So they'll give you their preliminary read, and if it's something that pops out like Noonan, they'll tell you right away, but their actual turnaround is closer to 3 weeks.
Okay, thanks.
There's
I'm
so
sorry,
many
and that's in
questions.
that was the neonatal. On the prenatal, they do cut off about a week.
Question says, you said that the BMI has an effect on the value of the NIPT or the free.
Yeah, so there appears to be with higher BMIs, there appears to be a dilutional effect. So diluting down the actual fetal fraction that's present, and that decreases the accuracy of the test. So sometimes they'll come back with cannot compute, get another sample, or the fetal fraction will be low.
So again, for our colleagues in different parts of the world, the NIPT is a screening test, is not a diagnostic test, number one. Number two, you're saying that, and of course the companies are saying a lot about the inclusion of 22q deletion as part of the panel for NIPT. So you say just ignore it for the time being, right?
Well, so the major societies have said not to use it. And I actually run the chromosome 22q clinic here at UCLA, and I worked at it in Philadelphia as well. And we, if somebody tells me for your patient, I have a 19% positive predictive value, I'm not going to order that test. With an 81% false positive rate, that's not reassuring. It's not diagnostic. So for this reason, the major societies thus far have not endorsed it. They've said, go ahead and do these, but nothing else, including the sex chromosomes. They're really unreliable. Thank you.
This is very valuable advice for the audience that, commercially NIPT is very, very popular. Now, when we start testing NIPT set 10 weeks onwards, till how many weeks before delivery, it could be a good significant test? Because some say, oh, you can do it at any time.
You can do it up until delivery. But at that point, again, it's a screen, right? So, at that point, it starts to lose value. And as I've shown you, it's really good for Down syndrome, but usually by that point,
Yeah. Okay. No, but it's still, if I do it at 20 or 30 weeks, the accuracy is the same. The number of cells, the free cells in the maternal blood.
Yeah. So remember, this is a screen, and it's entirely based on the assay is exactly the same.
Thank you so much. Thank you. I have a question here. It says from Carlos, the hypertrophic cardiomyopathy and hydrops is related to lymphatic disorders. Also, currently being studied at UCLA Improve with medical therapy. So I'm not sure where's the question here.
I think there are lymphatic disorders that you see with both Noonan syndrome and Turner's. Both are known. I have not seen that on the fetal side. I think Gary can speak to that more, but I know with Turner, often you're chasing your tail there, where the thoracic ducts keep filling up and filling up. But go ahead, Gary.
Yeah, well, no, Carlos is one of our senior fellows. He might be making a comment, not a question, if I'm not mistaken. So I think he may be adding information to the commentary. But yeah, I mean, I think we're learning more and more about lymphatic system disease in children with congenital heart disease and children with various genetic disorders. And they don't always, like all our patients, read the textbook. So I think the threshold or the bar is coming down with relation to a number of populations, including single ventricle and future Glenn Fontaine patients, on when do we need to know more about someone's lymphatic system, even if it didn't act up in the newborn or even the fetal period. So I think there's still a lot to be learned about the lymphatic system. The treatment that's happening is pretty amazing. These lymphatic catheterizations and the recent stuff that's being done. And many of you have heard about it and seen it, but I think the exact mix and match with the exact, genetics and lesions is non-specific to some degree. Yes, there's some that are more typically going to have it, but everybody in congenital heart care knows that these patients don't always do what they're supposed to do. Right heart disease comes with LV non-compaction. This thing does that. That's what makes so much fun with what we do and interesting.
I think what he was referring to are the recent advent of the MEK inhibitors to help with the vascular anomalies, and that will address those RAS-MAPK pathways. I'm not sure about Turner syndrome, but yes, those are coming. I have not seen that used fetally, but probably one day that they will be.
Thank you so much, Carlos. Sorry, I didn't get your point, but thank you for adding this. But Gary, the hypertrophic cardiomyopathy in Noonan, do you think it involves the whole heart or just one ventricle from your experience?
You know, I'm probably not the best person to ask, but my experience is it's more global. Maybe the LV and sometimes both ventricles. And again, we see sometimes have you not had a trisomy 21 who has structural heart disease and also has cardiomegaly or cardiomyopathy? I don't know I don't know if it's been studied. We've all seen it, but it's not high on the list of what we see, but we've all seen it here or there. So, you know, obviously the myopathies come with some of the genetic disorders on a lower incidence than the structural disease. But I'm not an expert in myopathy, so I don't know for sure what's the exact distribution.
It's very, very, very difficult. And Juliana, if I ask you about the why everybody sort of shies away from doing the genetic testing in dilated cardiomyopathy. I've spoken to a lot of geneticists, maybe I'm wrong, that, oh, it's very confusing. We're not there yet, dilated cardiomyopathy. Hypertrophic has been studied and a lot of info, but dilated ones, there are lots of families, there's X-linked, whatever. Is this still the same?
No, I think it actually has improved. So I would even say 5 years ago, we would say 15% pickup rate. And with the panels and with exome sequencing, that has actually increased dramatically.
Thank you. Diana, you want to ask a question?
Yes, I have a question for Selena. It's just about right aortic arch and the prenatal counseling. Because right aortic arch usually for us, unless there is suspect vascular ring, we don't really, need to worry a lot the parents. But there is a recent study that say there's increased evidence of genetic associations with George trisomy 21. So what will be her advice on counseling these parents prenatally, and what evidence is of doing postnatal screening?
Right. So I think it depends on whether or not there are other anomalies, structural anomalies beyond just the right aortic arch. And whether or not you think there's also a substrate for a vascular ring there, because then that starts to tip it more towards something genetic. So I usually look at the growth parameters. Are there any other findings in any other anatomic structure? I mean, obviously right aortic arch and a cleft palate is something completely different than just right aortic arch. But you're right. And then often that's just something that we don't know subclinically how many people who are fine who have those. So often those, depending on where they're coming to us, we can even defer into the postnatal period if there's not much else going on there.
And postnatally, would you do anything about it? It was just
cardiology, and then usually cardiology, and then usually they want one of us to come and look at the baby.
Oh, okay. We'll go into phenotype and see. Thank you so much. Thank you. Thank you for the sake of time. I think, Rosalind, it's very kind of you that you waited such a long time. And it's our pleasure to invite you to talk. Could you introduce yourself, please?
Sure. So my name is Rosalind Rivera, and I am the fetal and pediatric nurse coordinator at UCLA. So let's go ahead and get my slides up. All right. All right. Should be able to see them now. Okay, so I'm also the cardiac high acuity surveillance nurse at UCLA, and so I do fetal, but also postnatally follow the high risk, high acuity babies, our interstage babies, single ventricle. So just no disclosures. So let's talk about the team approach. Let me just get this, there we go. So as we all know, this is a team effort. We've talked about this. So typically starts with the obstetrician, the MFM, maternal fetal medicine, referral to the fetal cardiologist to do that fetal echocardiogram. In our clinic, we have a sonographer that does the fetal echocardiograms alongside the cardiologist. A nurse coordinator to help basically coordinate kind of the care of the patient. We also have a social worker in our clinic. She focuses on all of cardiology, so that's fetal and pediatric. And then, of course, the pediatric cardiac surgeon. There are definitely more members of the team than just these people, but for the sake of time, this is basically our core team. And of course, in the center of our team, really our team lead is that pregnant mother and their family. So I will be primarily talking about what the nurse coordinator role is and some of the things that I do in our clinic and just kind of in general, kind of the emotional aspect of caring for these patients. So, let's see. So we're going to talk about this CHD journey. So as you can imagine, when patients receive this new diagnosis in the fetal period, in that prenatal period, they're essentially embarking on a lifelong journey. And you as the fetal team is really the first stop along that journey, along this crazy windy road that they are about to take a new adventure on. So we're starting with that prenatal testing and care. So how can the fetal cardiology nurse assist with this portion? So of course, the fetal cardiologist is going to be providing counseling, discussing the findings of the echo, what the diagnosis is. So the nurses can be there. They can participate alongside the cardiologist to offer additional support by meeting the patient and their support person in clinic during that initial visit and subsequent appointments. I put in support person because sometimes, you know, your patients, sometimes they come in alone, but maybe they're there with their spouse. It could be a friend or even a parent that's coming with them. So just including them with that conversation as well. And if they're alone and you're going to be talking about a complex diagnosis, it's okay to also offer, you know, them to get someone on the phone, just so that they have their own personal support person with them during that counseling session. And then the cardiology nurse can also be the main point person in the fetal cardiology office. So, you know, the nurse offering their information, a phone number to call, a direct phone number, an email address for the patient to reach. Because as you can imagine, when you're delivering this diagnosis, it can be a little bit overwhelming. They may not hear everything that you say. They may not understand it. They probably will have questions afterwards. They might be calling you the following week. This is where your nurse can come in and offer some more support and education, talking again about the diagnosis. And so that's where you can utilize your nurse for this as well. And then coordinating future appointments and other referrals. We'll talk a little bit more about this later, but really being like the coordinator person for this new patient who has now a fetal cardiac diagnosis. So we're going back on that journey. The next step is the emotional impact. So this is a journey that parents are on, right? But you're there alongside them. And if you can imagine, this can be very emotional. For them to receive this diagnosis. They are essentially expecting a happy, healthy baby. And now we're telling them, oh, actually your child has a heart defect and here's this journey you're going on. So when I've polled some of our fetal patients, asking them their feelings when they were initially given that prenatal diagnosis of a congenital heart defect, as you can imagine, some of them were just devastated. Again, expecting that healthy baby and being shocked and confused. A lot of them feel guilty. Did they do something wrong? They're worried about losing their baby. So a lot of negative emotions are associated with this. And you can utilize your nurse to help manage some of those emotions, as well as understanding yourself as providers. So I'll talk a little bit about trauma-informed care. So trauma, as we all know, it's an emotional response to something bad that's happened. And that can be anything, really, anything bad that's happened. It's essentially a loss. And so trauma-informed care is just recognizing that your patients might have some trauma when they come into you. Of course, we can never know everything that your patient has gone through their whole life, and then has arrived in your clinic for this fetal cardiology appointment. And, you know, they can have trauma about various things that is then being reignited during this complex and sensitive discussion that you're having with them. And trauma for them can be, you know, the loss of a previous pregnancy. It can be the loss of a spouse or a family member. It can be even like a loss of a job. You know, these things are traumatic, and it's something that your patients are always thinking about when they're then receiving something else that's a little bit traumatic or devastating to them. It's something that it's going to be the way that they respond to the information you're providing is based on their past experience. So trauma-informed care really is just recognizing that is there, being aware of it as a provider. And then it's actually providing a safe place for your patients to develop a relationship with you. The point is really to try to minimize re-traumatization. It's empowering your patients. It's giving them safety and just creating that relationship so that they trust you and that they are feeling empowered as a patient who you've essentially given potentially some devastating news to. So trauma-informed care, it starts with some principles. So the first principle of it is safety. So as I mentioned, creating a safe space for your patients, having those conversations with them in a private room, no distractions, no outside people listening in, that kind of thing gives them some safety, and that creates trust, right? So you want your patients to trust you as you're delivering this information and talking about the diagnosis and expectations and essentially the plan for this CHD journey that they are embarking on. And then giving them choices. So that can be as simple as, the next appointment you want to have with them, giving them options of days and times as best as possible. Some of them are working or their support persons are working. So, giving them time options to choose from. And then also choosing what testing they want. Some of them may not want additional testing. So just giving them that choice, because essentially providing them this diagnosis is taking a little bit of autonomy away from them, because now they have so many other things to think about, and empowering them. So really giving them the information they need to be able to make those choices and to take care of not only themselves, but their now fetus, their now unborn baby, and what that will look like for their future. Collaboration, of course, goes back to that first slide I showed you with the teamwork. So it's not only collaborating with the other members of your team, but also with your patient, who really is the center, the lead of that team. And that all will lead to respect. So you want your patients to respect you the way they're going to trust you. Your patients will respect you as long as you respect them. Apologies about my dog. So just having that respect. And these are just the principles of trauma-informed care, and trying to include them all as you are taking care of your patients is something important to think about. So this is a quote I have from one of my patients, Caleb. Here's a picture of him. So his mom said, "When I first received Caleb's diagnosis of double outlet right ventricle, I remember clearly the doctor talking through the 3 different surgeries it would take. At 1 week, at 6 months, at 4 years. I sat and let the tears fall, realizing that they would be cutting open my baby again and again and again. I kept thinking about a future in which there were so many ways I could lose him." So as you can see, this is a direct quote from a mom, and just receiving the diagnosis and just really internalizing it, and then thinking ahead, like, wow, this is not just right now, this is basically the rest of his life. And, so it's really important as you're delivering this message to utilize the resources you have in your clinic, but also just recognizing that your patients, it's an emotional time for them. So just having that in mind as well. All right, so we're back on this journey. So next steps, we are going to be gathering information and finding their way. So this is your patients, right? They're gathering information about CHD. They're trying to figure out the medical world. Some of them may never have been in a hospital before, and so this is all brand new for them. So how do we help them? So I often tell my patients that, this congenital heart defects are like learning a new language, right? You're giving them a diagnosis and you're throwing all these words at them that they have probably never heard before, probably can't say themselves, definitely can't spell them. So it's like learning a new language. I remember the first time I'm like trying to spell coarctation. I don't know why. Couldn't get the C and the T in the right place. However, it's learning a new language, right? The more you practice, the more education you learn about it, you will become an expert. And so it's just, reminding them that this is difficult and we're here for them to help them through as they're trying to learn more about the CHD world. And then navigating the medical world, right? So this is something brand new for them. This is where your nurse can really come in. So helping to just be that coordinator person, the person that's kind of alongside them, helping them through those upcoming appointments, because it's a lot of things that, we're giving them a diagnosis and now it's like, we recommend this and this and this and this. And so giving them the choices, but so really just coordinating those follow-up appointments, trying maybe doing them on the same day if that works for the patient, or different days if that works better. So having that communication, and then coordinating other consultations. So in our clinic, we coordinate consultations with the pediatric cardiac surgeon. And that's just so that the families are prepared in that prenatal period. They have some plans for expectations, what the surgeries might look like for their baby. And then that also includes meeting with the neonatologist. So the neonatologist will run through what the NICU kind of treatments will look like. And again, it's just preparing your family so that they know what the plan really is going to be. So it's not so much of a surprise. Of course, there's always surprises, but you want to, this is empowering them, right? Giving them the information that will help them guide their own emotional thoughts around it. And another thing we do is a tour of the NICU. So we allow our parents to go into the hospital and just see what it looks like. Again, some of them may have never been in a hospital before. This is their first time and it can be scary, right? And so just giving them the ability to just kind of see what it looks like, again, helps them be prepared. Of course, these things might be overwhelming for them. So it's, again, giving them the choice. Would you like these consultations? It's okay to ask patients what they want. In fact, I recommend asking your patients what they want. Some of them it might just be too much for. And then utilizing telemedicine. I'm hoping that we can all agree one really positive thing that came out of the COVID pandemic was telemedicine, video visits, being able to see your patients without them having to actually travel to your clinic is so valuable. So for me, sometimes I use telemedicine to talk with patients after that initial fetal cardiology appointment. Sometimes, like I said, they call back in and they're like, I have questions, or I didn't really understand what they said. I try to use telemedicine if I can, because really seeing your patients face to face, while maybe not in person physically, but having that face-to-face connection actually does help them a little bit more, right? It gives them that support. They can see your expressions as well as you can see theirs. And so that's something really valuable that you can use. So here's Caleb again. This was just after his first birthday. So his mom said the first year of Caleb's life was hard. It was over 2.5 months in the ICU, unexpected hospitalizations. It was more than I realized it would be when we first received the diagnosis. But what I didn't foresee was that we would also be supported so well by a full team. When they came in for his regular checkups, it was joyful celebrations of his weight, his smiles, his spunk. And other residents, cardiologists that we'd seen in the hospital would also come by during these appointments. His mom said, we felt known. So this is just a reminder, like your patients, they remember you. Even if you see 10 patients a day, every single day, you may obviously not remember every single one of them, but they remember you. So your impact is very crucial, and just keeping that in mind as you're going through these diagnoses and utilizing your nurses for those times when you may not, as a provider, have the time to spend with the families. Your nurses and can be there to help with that as well. So supporting families. So what else can the nurse do? So just thinking about action points after that first appointment, being the contact person, providing the information to reach the clinic again, and providing reliable websites to consult. We all know our patients will want to go to Google and the internet and Facebook groups to try to find more information about this crazy diagnosis you just gave them. So it's really important to provide them with some reliable places to go to, reliable information. We often will give our patients little packets that have printouts from the American Heart Association or other reliable sources that talk about the diagnosis and expectations, so that they have that versus just going to a random internet website. And we'll talk a little bit more about some websites in a moment. And then make referrals. We talked about like any additional support that they might need, consultations. We also have a social worker in our clinic. So if there's any psychosocial needs that come up, referring them to the social worker who might be able to help with those things, or a psychologist for that matter. And then an opportunity to meet other families or reliable support groups, right? So the patients, this is something brand new for them, and it's often so wonderful for them to be able to meet a family who's gone through the same thing, so they can have those conversations. Because as providers, and we can talk to them for what we know, but we have maybe not gone through it ourselves. So having someone who's really had the same experience is very supportive for these families. Telemedicine, I'm going to talk about it again. Those video visits just are valuable tools that you can utilize. And then talking about follow-up appointments. So in the first appointment, I usually close it out with like, okay, this is what we're expecting for the next appointments. And eventually we'll talk about delivery planning. And of course, if they're talking about termination, providing grief support and just continuing to support your families through this journey that they're just starting on. So this is a website that I think is very valuable. It's chdcarecompass.com. It's not specific to any organization or hospital. And it provides really kind of like a lifetime of CHD care. This is just some snippets from the website itself. But it talks, about diagnosis. This is where I got that CHD journey roadmap that they're navigating from, but it has different reliable sources for them. So each of these little drop-down links has more information. It provides them other sites to go to. On there, there's quite a few lists of like support groups and educational websites to go to, so that this is like a one-stop shop for CHD care. So I definitely recommend using it for your patients. It does come in other languages than just English as well. All right, so we're on this journey, and now we are going through delivery, that surgery, managing a child in the hospital, and then really just living with CHD. How can you help your patients navigate just the lifetime of CHD that they are embarking on? So this is another quote from Madeline's mom. So this is Madeline, her mom. She said, "The medical team was there for us every step of the way. They prepared us for labor and delivery and for her aftercare." So it's really important to think, yes, we're in this fetal cardiology world and we're talking about the prenatal period and really taking care of the mom and the fetus at that point. But the reality is that this is a lifelong disease, and your patient should understand that, and you should be talking about that. And so I think as a nurse, it's really important for me for the families to understand that aspect as well. Yes, we want to get you to your labor and delivering and make sure that's safe and you're prepared for that. However, you also will be coming to see us once the baby's born, and kind of what that expectations would look like for them. So this is Madeline. Now she's actually a little bit older than this, but here's her and her mom. So, right, we want to get them to this care after that delivery period, after that prenatal period. So how can the nurse coordinator work in this manner? So collaboration, right? That's one of the main things too with trauma-informed care, is collaborating with your team. So we have interdisciplinary meetings once a month that just talk about delivery planning for any upcoming complex prenatal patients. So these meetings include our high-risk obstetricians, maternal fetal medicine, cardiology, neonatology, and then any other subspecialty that would be involved in the delivery planning for these patients. And we come up with a interdisciplinary plan. So of course, as you can imagine, the maternal fetal medicine physicians might want to deliver at a certain time frame. However, cardiology, like, well, actually, we should do this time. So it's having that conversation to do what's best for our patients. And then this communication about that. So one thing that I do is I send out a team email prior to the delivery of any of these complex cardiac babies. And by team email, I mean everyone. It's hundreds of people on this email, and it's the inpatient team, it's the neonatology team, it's cardiology, it's anesthesia, it's the surgeons, radiology, just so everyone's aware that this complex baby is coming, and so that we as a team can be prepared, right? And the families actually like to know this is happening. They're worried about the delivery. They're like, how will I know? They ask me, Rosalind, will you be at my delivery? Well, no, I work in outpatient, but I'm going to talk to the nurses who will be there. And so this email really closes that communication up so that the team is all aware. And that also provides some reassurance for the parents who are going into this meeting then new team members. And then follow up. So so in my role, I also, as I mentioned, take care of these babies postnatally after surgery once they're home, and do some of the home monitoring during that interstage period or during that first few months of life. And so meeting with them before the baby goes home, talking about, again, what that home care is going to look like, expectations for them, or that can be transitioning. So the fetal nurse can transition to the general cardiology nurse coordinator who will be then monitoring these babies at home or following them postnatally. So again, keeping that communication open, making sure that the things that are important for this family are being passed on through their care. So with that, I'd just like to say thank you. This is Caleb now, so smiley, and this is Madeline. She's actually older than 2 now. I think she just turned 3, but such a wonderful picture. And this is why we do this, right? We're really trying to empower our patients from that first touch point in that prenatal period for them to be, for their babies to grow up and be healthy and live a full life. So thank you very much.
Thank you so much, Rosalind. I just want to thank you for the warmth and empathy that you have for your patients. I think UCLA are lucky to have you as a nurse coordinator for their program. I just want to ask you, like, a case scenario, like practically, you had a case with a hypoblast or a case with a tumor. And we all know that in the first visit with a cardiologist and the team, usually nothing is clear that much. They go home and so on. So what will you suppose now we're a team? We sat, Dr. Gary told them that this is a hypoblast. He drew the diagrams and he asked for you, and you came and you sat and you gave all numbers. What is the next step practically? What will happen? Such a difficult case where you have more than one operation on the row coming.
Right. Yeah. So typically what we try to do actually at the end of the clinic appointment is schedule their next appointment. If we're not able to, then we'll call them to get that scheduled. And usually I'll talk to them at that point also, especially, each patient's different, right? So if they're having a tough time or they seem to not really understand, or I can tell sometimes when they're just not getting it, I'll call them and follow up maybe in a week or 2, or sometimes, they leave the clinic visit and they're like, we need to think about this. We're not sure if we want to come back. Those kinds of conversations. And so just a follow-up conversation, a phone call. I give them my card with my email, my phone number, as well as the Dr. Setu, the cardiologist. And then usually I will know when they're coming in the next time and try to see them at that appointment as well. So them having a familiar face is also helpful. One thing also I've been doing with some of our hypoblast babies specifically, knowing that they're going to need that home monitoring and several surgeries, is actually scheduling those Zoom telemedicine appointments. And usually later in pregnancy, once they've kind of digested a little bit more and have a better understanding, but just really just being a touch point for them is, I leave the appointments like, we want to have these things planned, the consultations. However, we'll touch base next time. You don't need to make decisions right now. And I think that's another thing, is to just kind of meet them where they are, and giving them the choice about their follow-up appointments.
And also, I remember it's very important for our audience from different parts of the world that we tell the parents, don't go for Dr. Google, because a lot of bad info can come from that, and parents are frustrated. Whether even I get patients, everything in all languages in Google. So don't know who puts the information there. So I think providing the websites as an info. And then as the pregnancy comes to term, do you think there will be more load on you as a nurse, or do you think they need like more social support, those mothers with difficult cases like hypopasts and so on?
Sure. I think that, it's really a team, right? So working together and ensuring that they know that we're there to support them. So by being available, right? So if they reach out, then, definitely replying to them or calling them back. I think as it gets closer, all moms nest and prepare for their baby to be born. And this is a different way of preparing. It's preparing like for the medical aspect and what being in the hospital is really going to look like for their family. So yes, definitely as they get closer to that delivery time, being there to support them and just reminding them of the plan. And then also reminding them that the plan could change. So just being realistic as well.
Did you, Gary, as well? Did you get a patients where you had to ask for a psychologist or psychiatrist to come on board?
Yeah, that's a good question. Well, so I would say as far as psychiatry goes, pretty rare. We do occasionally have patients that have mental health diagnoses or mental illness. More commonly, we can have, increased depression or other things that get exacerbated by the diagnosis and the counseling. Rosalind's amazing, as you're learning, and nurse providers like Rosalind, who are part of fetal teams, play such an important role and often help to diffuse a lot of the, at least diffusable for any given patient, feelings and emotions to a level that's functional. But occasionally you get, very rarely you get patients who are it's too much. And sometimes, depending on the gestation and again, where you are in the world, in the United States, a pregnancy may not continue for those reasons, among others. And other times, what's more common is we need a social worker involved. We at UCLA, like many centers in the United States, have a mixed demographic patient population, but we have a fair number from very underserved areas. And these patients sometimes don't even have an automobile of their own to get to the visit. They have to arrange for a friend or public transportation that may be very time consuming in a large city like Los Angeles. So now you're going to talk about multiple prenatal visits with all kinds of specialists and all kinds of planning, and they may not live very close by. How are we going to make sure we don't deliver out in a, underdeveloped area, et cetera, et cetera. So a lot of anxiety and stress comes up, not just from the cardiac diagnosis, but the altered lifestyle, both short-term and long-term implications of the diagnosis. But I would say the large majority get managed by all of us, the team, our social worker in pediatric cardiology, and there's more of those types of care members in the hospital when the mom's admitted, when the baby's born. And when we follow them, like those patients of mine you saw who are now older after the initial experience and need maybe a different level or a less frequent level of care at that level, but still may need something.
I always think of the young ones, you 13 and 14 that get pregnant, and I've seen that with a baby, with a fetus with a complex heart disease. I don't know, both are children to me. And so is this an extra burden for you as a nurse coordinator, having a young mom or single young mom as well, or a couple that are both young? The couple are both young and with a complex heart disease. Is there special precautions or special way that you tackle such cases?
Yeah, so I think knowing that these patients are coming in ahead of time to maybe get the social worker, make sure that they're available, but then also just really like meeting them where they are. So a teenage parent may not really be able to understand the medical things we're telling them. So just, you know, talking in essentially layman's terms, or talking in terms of that they will understand. And then again, it's the follow-up, right? So it's, you know, education and teaching them over and over again, telling them multiple times. It helps them to essentially digest it and understand it a little bit better.
You ask them to bring their, for example, can you bring your mom with you next time? Is this allowed in counseling, or something like that? Do you? I've seen the mothers coming in with their children, with a pregnant a teenager and stuff like that, and I could sort of correlate more with the mom, the grandma, rather than the patient. So, any advice to our audience who face such things? Like, I also want to know if they're keeping the pregnancy till the end or not. This is another issue with such young pregnant moms. Is there any advice in these cases?
Yeah, I think one thing that we do, especially where it seems like it's a complex social situation, is really talking to them about the long-term plan. You know, it's not just you have a baby with a heart defect, what does that mean now? It's the lifelong care that baby will need, several appointments, medications, surgeries, and so that they really know like what they're signing up for as a new parent. So I think, and then definitely having their support person, and that can be a parent. We definitely allow parents. We allow a spouse and a parent if they'd like. I mean, we have some patients that are in their 20s and 30s who bring a parent as well. And of course, we want them to have that support person, because it is, you know, a complex and sensitive conversation that we're having with them. So having someone that's there to support them, that's their person, is very important to us. So I think that should be thought about.
Thank you so much. Any questions? I've enjoyed this session. I'm sure our audience did enjoy the session. Any questions? How do you charge for this team approach? There's a question from Patricia. How do you charge for this team approach? I don't get that. It's a service that's, I think, offered by the hospital, right? You charge separately?
No, not for me talking with them, no. Typically, the telemedicine nurse visits are not charged. A physician visit would be, yeah.
So from the genetic side, for some of our complex patients, they are charged individually. So the MFM will bill, cardiology will bill,
Yeah,
and
of course.
Although we all meet and talk as a team.
I would like to thank all our speakers, and I've enjoyed the UCLA staff, and hope to get you soon back. And I'd like to thank our audience with us or live on the YouTube. And I just want to remind you that you can always go back to this session on fetal series on the YouTube on Congenital Heart Academy. And we hope to see you with the next webinar. Thank you so much.
Thanks, Rima.
Thank you.
All good? Bye.
Thank you.